All right, so we're going to start off where we left off with pediatrics. We have to be done this stuff by Wednesday, and then I think Monday we're going to do the last two, and then after starting February 2nd, you guys are going to have straight labs until we do the group project. So we're going to see how far we can get, but the goal is to be done all of lectures by the end of either next Monday or beginning of Wednesday. So, which isn't bad. The last two chapters, I think there may be 5 questions on your state exam from those 2 chapters. It's not a, they're not horrible. We'll talk mostly about triage, and that's really the only thing you actually kind of need to know about that is triage and hazmat. Okay, so we left off with pertussis. I'm going to play some sounds for you because we had some whooping cough or croup and pertussis kind of sound the same. And then kind of see if I can do this for, nope. All right, that's still not going to work. All right, so we'll start with the croup sound, which is super easy. Oh, she did say something about the sound wasn't working. No. Okay. Apparently nothing's going to work. That's usual. Why can't things just work the way they're supposed to?
You have to start drinking more water. You wouldn't believe how dehydrated most people are. Number 2, you need to make a decision. Not to say you should go against your current doctors, but you don't have to settle for a handful of pills. This is as good as it's going to get. Number 3, tell them to raid their own refrigerator. Even people that think they eat healthy overall don't realize just how many of the foods they have eaten basically their whole life keeping them healthy. 5 foods listed as the worst foods for arthritis. Most of my patients eat at least 4 of them every single day. Within days of eliminating these foods from their diet, their joints.
That's the longest ad ever. That's what I'm looking for.
This YouTube channel is aimed at helping you understand complex medical topics and breaking them down into bite-sized, easy to understand chunks. So in today's video, I'm going to go over what you hear with croup and give you some real-life examples of sounds, which will hopefully be really useful as we come into the winter season. But before we listen to these sounds, let's first of all go over a quick recap of what croup is, what causes it, and the symptoms of croup. So croup refers to infection of the upper airway, which obstructs breathing and causes a characteristic barking cough, which is typically found in infants and young children. Cough and the other signs and symptoms of croup are the result of swelling around the voice box, which is known as the larynx, which pipe, which is known as the trachea, and bronchial tubes down in the lungs, which are the bronchi. When cough forces air through the narration passageway. Swollen vocal cords produce a noise similar to a seal barking, and that's the characteristic barking. Likewise, taking a breath often produces a high-pitched whistling sound, which is known as stridor. It's most typically caused by parainfluenza virus, but it can also be caused by respiratory syncytial virus, also known as RSV, influenza, adenoviruses, or enteroviruses. So now we've covered a little bit about what croup is, but what are the symptoms of croup? Well, croup often begins as a typical cold, and if there's enough inflammation and coughing, the child can develop a loud barking cough that's further aggravated by crying and coughing, as well as anxiety, agitation, and that sets up a cycle of worsening symptoms. You can also have a fever, a hoarse
Here
voice,
is the.
breathing that can be noisy or laboured, and these symptoms are
Oh, it is coming out of there.
nighttime.
I just can't hear it.
Last 3 to 5 days. But if they don't, then the child might need to seek further medical attention. So now that we know croup cough sounds like a typical barking seal, let's have a listen to a few children who actually have croup to hear what the sounds are like. So how do you manage croup? Well, the good news is
All right, so you can hear that barking, kind of stridor, that wheezing when they suck in from when they're trying to cough versus
Whooping cough. It's a bacterial infection that's risen to epidemic levels in some parts of the U.S. In a... And he couldn't catch his breath. When they often had subsided, so they think. Had subsided, so they figured it was just but Chelsea knew there was something else wrong. Practitioner saw it and diagnosed it right away.
so you got the, you hear the difference? Kind of, sort of, like they're very similar. They will both have stridor. You will just find that the pertussis sounds a little bit more junky. It's got that like almost like pneumonia cough sound to it, whereas the croup has the like dry barking cough to it. You also have the running nose. Okay. So those are the two differences between those. The treatments are still the same. There's nothing you're going to do differently for one versus the other. It's just knowing which one you have. All right. They're still both oxygen, whether it be blow by or if they let you put the mask on, right? Keep them upright. Suction if you need to suction. Okay, if there's excessive drool and whatnot, and then go from there. No, are we not? Nothing gonna work today. Is it not changing anything up there? How about now? There we go. All right. So, like I said, other pertussis, we should all mostly be vaccinated for. I know it was a big thing as part of your childhood vaccinations. You may find people who aren't vaccinating their children these days, so they may or may not run into it. It was pretty much all but eradicated in North America, and then it's starting to make a comeback again. So just be careful, it's out there. Put gloves on, put a mask on, do your stuff. All right, shock. So who thinks shock is any different in children than it is in adults? One person, two people. All right, good. Three people. Okay, what's different? It does take longer to hit the decompensated the phase, or for you to know that they're in the decompensated. It may take longer for them to get there, but it will take longer for you to know that they're there. That is true. What else is different?
The decompensated phase also happens much quicker, right? Like
Hmm.
once you hit the decompensated shock, like you are kind of like out of time.
Yes, yes to both of you at the same time, which is why I had to make you repeat it because she was talking too.
Oh, sorry.
No, you're fine. You're fine. Yes, they both will decompensate once they start a lot more rapidly. Okay, to going down into irreversible versus something we can do about. Okay, so again, shock develops the same exact way. All right, most often in children, we're worried about trauma or dehydration, possible infection, or some sort of injury. Okay. Again, anaphylactics, they're pretty prone to because they're constantly putting stuff in their mouth. They have no idea what they're allergic to. This is where you start finding out what they're allergic to. All right, so kind of tends to happen. Congenital heart disease is one of them. Depending on how busy they are, tension pneumos, falling down, bouncing around. Okay, that kind of stuff can happen, right? Or they are susceptible to cardiac tamponade and pericarditis and trauma as well, right? So when pediatrics lose fluids, their heart rate's going to go up. All right, their respirations are going to increase. Okay, and then their skin might get pale or blue, depending on how well they're perfusing or how much blood they've lost. All right, so just be careful, which is why it's kind of hard because they already have an increased heart rate and increased respirations. So how are we supposed to know whether it's higher than normal or higher than that child's normal? Okay, so just be aware. Tachycardia, other outside those normal ranges. All right, port cap refill is a good indication, all right, of your perfusion status. Mental status changes, obviously. All right, and then we obviously do the same thing. Okay, this happens in adults too, more so in children though, where we go, especially like in cardiac arrest situations, we'll do CAB versus ABC. Okay, we start worrying about circulation first. All right, obviously, in the face of a life-threatening hemorrhage, okay, we worry about the airway and the blood, or airway and the breathing. By the time we get to circulation, there's no blood left. All right, so we got to stop the bleed first, then go back. All right, it's the same process in CPR. We worry about circulation first because we're trying to push that oxygen that's left inside the blood cells and inside the lungs before we add any more. Okay. And then, like I said, these guys, you're not going to get any vital changes until the very end. All right, they'll be decompensating before you know. All right, so again, simple stuff. Oxygen, control the bleeding, right? Always maintain airways. What else? Which one am I forgetting? What's our three things for shock? I forgot one on purpose. The blanket. There you go. Right? Airway, oxygen, bleeding, blanket. Okay. Again, we've talked about this. You're going to give them the oxygen whichever way they will tolerate it. Okay. Position to comfort, blankets and heat, immediate transport. And yes, this is the one time I would always call for ALS is when I'm dealing with pediatrics, especially with severe pediatrics. Because again, you just don't know where they're at. So again, anaphylaxis, we know it's the same thing. What is the pediatric dose of epinephrine that we give?
0 0.15.
0.15. Yep. So it was 2 people, so I just waited for her to finish so I could get it. All right, good. And we can do it one of 2 ways, right? What are the 2 ways we can do it? Check and inject in the auto injector. Yep. Okay. All right. So they're gonna have the same symptoms we do. All right. They're gonna be hypotensive, possible wheezing, definitely breathing. All right. Probably gonna be agitated and restless, hives, urticaria, all that good stuff. All right. And then again, we're gonna do the same thing. When needles are involved, I would definitely let the caregiver hold on to them, just because they might be able to calm them down a little bit, talk them through it. Depending on the age, they may have already had shots. They might have a routine for it. Okay, so it also gives that child a little bit of calming presence. Unless mom or dad is freaking out too, then it's not really worth it. But, and of course, our favorite rapid transport. All right, hemophilia we talked about during the last chapter. It is pretty much the same. Okay, so just be careful because the children don't have as much blood to lose. All right, so altered mental status. Okay, these are some of the mnemonics that we use. All right, AEIOU, alcohol, epilepsy, electrolytes, insulin, opiates, uremia. Okay, I should hope a kid is not getting into opiates, but we are talking from newborn to teenagers, so be ready for everything. And then tips is trauma and temperature, infection, poisoning or psychogenic causes, and then literally anything you can think of that starts with S. All right, shock, stroke, seizure, fainting, hemorrhaging, right, brain bleeds, all that good stuff. Okay, so just be on the lookout for everything. The state loves their mnemonics. Okay, and then right, altered mental status is the same for us, right? It can go from simple confusion to all the way down to a coma, right? And again, all we do is ABCs, transport. What else can we add to that? What did I say about altered mental status? What else can we do?
Glucose.
Glucose, right? Any altered mental status patient, for whatever reason, you should do a glucose on. All right, just to cover yourself, because it might be simple. All right. Seizures, again, in children, especially in infants, they may not be as noticeable. All right, they might just make sucking sounds. They might just kick their legs in like a normal repetitive behavior. Okay, so it might not be as obvious. You may not get the whole grand mal shaking. All right, the febrile seizures, usually you get the grand mal, but like the diagnosed neurologic seizures are usually pretty subtle. Okay, the older they get, the more muscle tone they have, the more obvious they become. All right, so again, any type of head trauma, right? More so than child abuse, but they're talking about the head trauma. Electrolytes, fevers are the big ones. Hypoglycemia, sepsis, ingesting something not supposed to, right? Hypoxia, getting into someone's medications or under the cabinet or into something they're not supposed to get into, right? Whether they have a seizure disorder. Okay, and then sometimes we just have seizures because we do. All right, so again, postictal is exactly the same. All right, the longer they seize, the longer it takes to recover. That's the same for everybody, right? And then as soon as they come back to an A&O state, it's over. All right, status epilepticus is exactly the same, right? So every few minutes without regaining consciousness that lasts longer than 30 minutes. Just a recurring seizure that won't break no matter what you do. You can give them Versed, it won't break, right? You can give them their own medicine if they have it and it just doesn't break. The VNS stimulators don't break it. All right. And again, these ones is more about protecting the patient, suctioning if you have to, maintaining the airway. right? And then call for help. Okay. So again, I just talked about the rectal diazepam. All right, so just make sure that they're not having a reaction to it. Okay, sometimes you may be asked to do it. They're not comfortable. It's a little suppository up to your first knuckle. All right, and then just let it go. I had to tell you about the on the fly suppository I had to do one day. No. So I had an adult having seizures. I can't believe I didn't tell this in my seizures. Large girl, she's about my size. And she was seizing. I had to tell you the story, a couple hours, right? They were driving. Yeah, they were driving to Poughkeepsie. I didn't tell you about having to on the fly make a rectal. Okay. So I'd given her all of the Versed that I basically, first dose, I given her first 2 doses. She's in status epilepticus. It's not breaking. So I called the doctor. What do you want me to do? He's like, rectal. And I'm like, I don't have suppositories. He's like, what do you mean? I carry a vial. He goes, okay, you got a syringe and some tubing? Yeah. He goes, make a suppository. I'm like, I guess you're right. So took out a syringe, took out an IV tubing set, cut off maybe a 2-inch portion, fed it on top of the syringe after drawing the medication through it, had my partner stop because I couldn't roll her and hold her carefully while driving to do everything I wanted to do at the same time. So he came in the back, held her, pulled her pants down, stuck the tube in the rectum, and gave her the rectal Valium. First time I've ever done it, and probably hopefully the last time I've ever done it. But yeah, no, I had to make a makeshift one out of a syringe and some tubing. So, oh yeah, within like 2 minutes. Like she finished her last seizure, she was done. I went back to the hospital like a couple hours later, and she was still sleeping it off. Yeah, I mean, at that point she'd had 15 milligrams, so she was quite well dosed. But yeah, it's amazing what you can do literally out of nothing sometimes when you think about it. But yeah, no, I would have never thought about it. I mean, I didn't want to do it, but something about a baby I'm okay with, but I don't want to stick something up an adult's rectum. Like that's why I'm in EMS. We don't deal with that too much. All right, so meningitis, moving on, is a bacterial infection of the lining of the brain and spinal cord, right? So it's usually in pediatrics that get this. Sometimes it can be in adults. All right. There can be just like a nervous kind of ticking motion of a body part. All right, depending where the infection is, they can like just, but it's usually like in a cadence, like it'll be repetitive, exactly the same, and they won't know they're doing it. They have no idea. Like if they didn't see it, they wouldn't know. They're like, I'm not doing it. I don't know. I can't stop it. Right. And they're just like doing this for no reason. All right. So again, it's more often in males, more often in newborns. Okay. Any immunocompromised can make it worse. Any type of surgeries, we always expect it, especially if they're starting. Let me make a broader statement. Anytime there's a surgery and someone calls and they're not feeling well, always check the surgical site for infection, because that's 9 times out of 10 the culprit. Okay, they either didn't clean it properly at home, do whatever they're supposed to do, maintain their care, post-op, right, rehab stuff. Okay, especially PICC lines. PICC lines are very easy to get infected. Okay, so if they say I have a PICC line and they say they're not feeling good, they feel feverish, check the PICC line, see if it's red and swollen. Right, Mark, do you agree? Surgical sites tend to get infected coming from a surgeon. Okay, it's usually a good place to start with. All right, so, and then we'll talk about shunts in special populations. I don't know if I have a video of the surgery of shunts or not, but I do have one for the VNS. It's pretty cool. Okay, so meningitis is usually a fever with altered mental status, possible seizures, but again, what do we think the seizures are due to? Probably the fever, right? Could be the infection since it's with the brain, depending where it is, but most oftentimes it's related to the fever. Okay, and then very young children who get it, they can end up not breathing, blue, all right, hypothermic, all the good stuff. Okay. Again, there's not much we do with it. In older children, it's mostly that stiff neck. They start feeling stiff or sore. Okay, that's what leads people to think about it. The bulging fontanelle, right? I told you those fontanelles will tell you everything you need to know about your infants. Okay, will tell you whether they're hydrated, not hydrated, perfusing. Okay, if it's bulging, that means there's something underneath it pushing it out, right? So all right, that's the actual bacterial name. I'm not going to butcher it. Okay, again, if left untreated, it will cause shock and death. All right, and you may see small pinpoint, like bright red spots. All right, or lesions. There we go. I was like, I think we have a picture. Okay, so you see that kind of rash. All right, this kid looks kind of dehydrated. His feet are all ashy and white and scaly. And is that an old lady? Doesn't that look like old lady legs for a minute? Anybody else think that's old lady legs, not a pediatric set of legs? Like the book just put them in there in the pediatric chapter for no reason. Right? Does that look like a kid's legs? Older child. I mean, yeah, I was gonna say, I'm not gonna say that like I have a foot fetish or anything, but I've seen a lot of old people feet and they look like old people feet. Like they look like old people scaly, like I can't reach my toenails to take care of them anymore kind of feet. Like yeah, it's kind of just like a little rash. Like that looks like the nail folding under the toe. Yeah, those look like old people feet. That's what I'm saying. That's more of like I would expect abuse if that was a kid's foot with the how dry the feet are and the scaly and the looks like they're dehydrated. The amount of extra skin, like saggy skin, like up in this area, like right up here under this calf, like that should not sag on an infant or a newborn kid, unless it's all like lymphedema or swelling. But then even then, this looks like varicose veins over here. I mean, a kid's feet could swell, but yeah. Oh yeah, no, that definitely looks like some CHF going on too. Plus the feet just look like that big. All right. So again, meningitis is contagious, right? So BSI, seen safe, right? Do your little spirit fingers walking in. Make sure you got all your stuff on. Okay. O2, ABCs, right? Make sure the vitals are good. They're having chest pain or, if you think they're deteriorating, call for backup, but otherwise it's pretty benign. Not much we can do for it. Okay, abdominal pain. Again, this is NDP's policy for abdominal pain. Every abdominal pain is supposed to go ALS. All right, because who knows? It could be literally anything. All right, it could be a GI bleed that hasn't shown itself yet. It could be a benign like cholecystitis, right? But their policy is you have no clue. All right, and they can change at any time. So just be careful with the abdominal pains. All right, they can be more severe. All right, in kids, it's usually pretty organic. All right, could be a food, a substance, an item, right? Kids like to put everything in their mouth. Okay, usually, hopefully they either vomit it back up or they kind of have to wait till it gets passed. Hopefully it doesn't cause an obstruction, bless you. All right, and then the old appendicitis. All right, which is the most, I want to say vicious of the unsuspecting syndromes, but appendicitis will kill you if left unchecked. And most people really don't even realize it's happening until it ruptures. So. What? Oh, you've had the appendicitis. You still have your appendix, or they just yank it out? Yeah, it's usually what happens. Huh? When you were 4. Okay. So what do you want to tell us about appendicitis? Well, we know it's painful. What else? Okay. So I don't know if you guys heard her, but she said that her mom thought she had the flu, and then when she was screaming with abdominal pain and vomiting, they took her in and her white blood cell count was elevated for her age, and that's how they found it. So, all right, again, for whatever reason, also like if you palpate down here and they're guarding, right, should be down here. Okay, if they point like in this area, lower abdominal pain to the right, and you start palpating and you feel firmness or it's hot, all right, or you go to touch it and they push you away, right? That's where we suspect it, and we're gonna get them moving. They're not old enough to talk yet, right? We talk to the caregivers first. Okay, how often, right? This is where your oral intake and your intake and output, or your input outputs, right, are important, because we want to know if they're dehydrated or not. Okay, why are we worried about tears? Right, that's a late sign of dehydration. If you're crying and you're not producing tears, all right, there's no fluid. All right, so we want to know about tears. Okay, good. Poisoning. Again, we talked about this. Most common ones for children, stuff left out by the parents. Okay. And then houseplants, right? Like I said, they put everything in their mouth. And we know that we do keep some houseplants that are toxic. All right, but we know better. And they don't. All right. Again, vitamins, right? They think it might be candy. Okay. Certain vitamins are toxic in excess. Okay, so you gotta be careful. Did they get any medications? Right, older kids, they get into street drugs. All right, we talked about all the signs and symptoms. They're all the same, so you don't have to worry about too much about being any different. Okay, try to find out the same types of questions. What they take, how much they take, when do they take it? Right, what else are we concerned about? What else are we concerned about in an overdose or a poisoning? Are they vomiting? Is the airway clear? What else? It's up there, I just didn't say it.
Abuse?
Abuse? Well, possibly, no. Right, what's their mental status? Right, what's their behavior? Are there any changes? Right, what do they get into? Should we be looking for behavioral changes? Right, use poison control if you think it's necessary. Okay, again, if it's on something they got into that's on them, wash them off, decon, and then obviously ABCs, breathing, treat for shock. All right, I keep adding the charcoal. It's got a couple people on the test. All right, nationally, we still give charcoal. The state of New York does not. All right, you have to remember, for your test, you are allowed to give charcoal. When you start working in the New York State or doing stuff on campus, you will not have charcoal. All right, so. No, Epicac's been gone since before I started. That's even worse. Yeah. I mean, I understand it because, the hospital's going to pump your stomach anyway or go in and do what they're going to do. So everyone was like, if we just start them vomiting in the field, that's great. However, right. After everything I've told you, Joe's face got real weird real quick. Right. What's wrong with having them start vomiting in the field, Joe? Well, yeah, I'm not cleaning it up. I'm going to be vomiting too, but from a patient standpoint, what's wrong with having them starting to vomit in the field? Oh, there could be that. What else? Right. Airway aspirations, right? What happens if they go unconscious and now they're still projectile vomiting because their body has the syrup in them? but they lose mental status. Now what do? Yeah, try to suction the best you can, right? Because now you're really screwed, which is why we don't have cerebrovipac anymore. Because it did a lot worse than what it was supposed to do. Right. So we talk about dehydration in kids only because, again, it's more prevalent, right? The vomiting, the diarrhea. Okay. Again, skin tenting, right? You should be able to pinch the skin. It should go right back down. All right. If the skin sits here and folds and stays there. All right. I always get nervous. Sometimes it actually does. I'm like, I'm dehydrated, but I'm apparently pretty good today. um, yeah. Yes. But you take the national test. So you can get the national certification, and the NREMT will accept your skills exam, and within, I think, like 3 or 5 months. And then if you've just taken the test, like, they'll accept your test as well, versus making you retake another test, which is why most of the times, like, if you want to pay the $100 to get your national, so you can do reciprocity, like for the BARD students, if they want to work when they get home somewhere, it's a lot easier for them. So the test you're going to take is a national style test, because it counts for other stuff. So that's why we kind of have to give you the national versus the state. I mean, honestly, we could teach you just the state, tell you nothing about the national, and the amount of points that you would lose not knowing anything about it would not be enough to fail you. However, should you have a bad day, like, you may need those 2 or 3 points. So it's kind of like, when you see this, remember to answer it this way, but that's it. That's the last time you answer it that way, like, and then start doing it this way. I know it's confusing. I hate it myself. I'm trying to think. Sal has the breakdown. I'll get him to email me the breakdown. It's broken down by section. So there's like 30 that come out of medical. There's like 20 or something that come out of. That's what I'm saying. Like, if I knew the breakdown, I don't know the breakdown. Because I thought it was one of those where once you've answered enough per section, like, it cuts you off. Some people get 50 questions. Some people have gotten up to like 120 questions. Like, I think there's, once you show a proficiency in that section, like, they don't ask you that section anymore. So, and this is what I've been told by people who have taken it. If you can start the test, right, and you're getting a random generation of all of the sections, and all of a sudden it starts asking you a whole lot of like respiratory questions and nothing else, it means like you've done good on everything else and you've screwed up the respiratory section. So you better figure this stuff out. Like, you're getting close to them cutting you off, saying you failed. All right. But also, most people who have an 80 or better average in this class have not failed the test on their first try. So, which I was talking to her the other day, we kind of do on purpose. We make it a little bit harder. And that way, if you can pass what we're teaching you in here and understand it, like, you'll look at that test and be like, damn, this was easy. No, you will be absolutely fine. I mean, I was a little disappointed at some people on the heart diagram. I can't do anything about that. That's anatomy that will be on the test. I can promise you. You have to know that diagram. That's why I put it there. You will probably see it again, even though I'll put it on the geriatric question until everybody starts getting it right. I thought that was like one of the cleanest, like, non-cluttered. The lines were all on the outside. It was pretty easy, but I will make it a little bit bigger. If you put the little thing on all of the dots on the outside of the screen, that whole inside wasn't cluttered. Everybody tried to put the label on the actual part instead of using the line that it was attached to. But that's my fault. I didn't put that in the directions. I thought that was assumed. See, I just have to be, this is learning as a teacher. I have to be more explicit with the instructions to make it easier for people. And a lot of people were good. A lot of people, the only thing people were getting confused were the mitral and the tricuspid valves, on what side they were on. And that was mostly the only thing people were getting wrong. I was surprised that people actually found the descending aorta on the bottom. It was about this long. It was about this tall. It was like sticking to the very bottom of the heart. Yeah, but if you're not looking for it, it was kind of hidden. There. That's why I said if you followed the lines, it was pretty easy. But I even looked at it and I was like, ooh, that one's going to be the one everybody gets wrong. And I'm just waiting for people to complain about it. But it was the cleanest one I could find. The 12 lead, we're going to go over the 12 lead in labs because that seemed to throw everybody off. Everybody wanted to do a straight line below the nipple, like just straight across the heart. Like 1, 2, 3, 4, 5, 6. And like, but it was all like a straight line underneath. It wasn't like 1 and 2 and then the horseshoe. There was no horseshoes. Everything was in a straight line. So we're gonna have to go over that a little bit again. But, and I did give you guys credit for where you put the limb leads, whether you put them on the core or on the limbs. Because I did say, depending on the manufacturer, depends where they go. So I did give you credit for either or, as long as they were not like stacked somewhere they weren't or on the wrong side. Basically, I gave you credit. There's only 10, but it gives you 12 different views. So there's 12. All right, without getting into cardiology and especially EKGs. All right, we have the heart over here. All right, and then you have your limb leads. All right, and then with just the limb leads, there's 4 directions that the electricity flows through the heart to give you 4 different views of what's happening. Okay, so it's all about which direction the electricity is flowing through the heart, between which 2 electrodes on the patient that it's reading. Okay, so through those 10 electrodes, you get 12 leads or 12 little pictures. The electrodes, the actual snappy parts. Well, there were 4 pulmonary veins there. You could have labeled all 4 or just one. No, I don't think it's a glitch. I think it's the way I set the question up. I think I set it up that there's infinite targets. Yeah, so I think like when I go back and I'm still learning how to do the diagrams. I'm trying. All right, this is a process, which is why I give you guys credit for, like, if there's 4 things up there and one of them is in the right place and the other 3 are kind of like haphazard, I'll take the one that's in the right place. And I'll be like, well, they probably just thought they had to keep using it till it disappears. So I may have to just put 1 target, like when it says number of targets and I just say infinite, I may have to put 1. And we'll see how that works. Well, because you have to save it. You have to save your answer. Yeah, that makes sense, especially if I give you infinite tags. So I'll look at that the next time. We have a test coming up the end of this week, so I'll put another heart diagram on there. Like I said, you guys, until everybody gets it right, we're going to keep seeing it from here on out. Maybe I'll make a smaller one. We'll call it a pediatric heart, make it harder for Joe. Maybe I'll put what is the hole in the baby heart called when they're first born, where the atrium and the ventricles are still connected, or the septal wall's open? The foramen ovale. Yeah, maybe I'll put that one in there as bonus points. If you can remember what that one is, we'll give you some bonus points for that, huh? This guy over here. Nothing. No, you didn't. I don't have an attempt for you. Yeah, that's why I know you did a heart drawing, but I don't have a grade for you. which I was like, which I told you two didn't have to do the test because you're refreshers. He still did it. And I was like, oh, this guy over here, he's gonna be the one who's like, no, I'm all good. Did you do it or not do it? Okay. No, you don't. They close Sunday at 11. No. No, that's good. That's fine. I'm not worried. Like I said, you don't have to do it. I don't, that was up to you. I was like, oh, all right. But either way. All right, let's go back to dehydration. Okay. So again, dehydration, all the same. All right, dry lips, no saliva, no output. All right, sunken eyes. Really look forward to that sunken fontanelles. Like those will be your first clue. All right. Cool claim of skin, no perfusion. All right. Decrease, what's CRT? I just didn't feel like typing. What's CRT? Anybody? Capillary refill time, right? Since we're talking about perfusion signs. Okay, so delayed capillary refill time. All right, and increased respirations. And there you go. That is what my hand will usually do. All right, but my hand does not. Apparently, I've had enough coffee today that I'm hydrated. No, when he lets go of that though, that's going to stay that way, and it's going to very slowly go back in. It's not going to just go like if you stretch it out and let it go, it should snap right back. Yeah, but it should not stretch that far to begin with. Right, like mine goes this far. They're like that's it. All right, like yeah, like if I could pull it up to here, okay, that would be. Oh well, I'll find you one. We got 9 minutes till a break. I'll find one. We can show. I'll show you a poor tenting video. I really didn't want to depress people, but I can show you some dehydrated baby videos that'll make you get angry. I usually try not to show like kid videos because people get really upset and angry, like abuse issues. And I'm like, okay, but it's a video. What do you want? I don't know where it came from. I don't know who it is. I don't know where they are. Like, there's nothing we can do about it. Huh? It's all me. Yeah, I'm the one. Okay. Fevers. All right. I think it's actually lower now. I think it's 100.3. Right, Mark? You know, 100.3 is the actual definition of a fever, or is it still? I don't know. They changed it. It's either 103, 104. Okay, 100.3 or 100.4. All right, it's technically the clinical definition of a fever. Up until then, like in the 99s, it's not really a fever. Okay, you pull in with a 99.9 temp, the doctor, especially Dr. Gutman, before she went to Bermuda, lucky her. I rolled in, I tried to call a code sepsis. Person had 100.1 fever, and they had the hypotension, the tachycardic, everything. She looked right at me, stone cold, was like, it's not sepsis yet. I'm like, what are you talking about? They don't have a fever. I think it's 100.1. She goes, yeah, the definition of a fever is 100.3. They don't have a fever yet. You can't call sepsis. And I'm like, are you serious, doc? She goes, oh, I'm just letting you know. But yeah, you know, they're septic. I was like, stop it. She would bust my balls all the time. But she was cool. 100.4. Okay. So yeah, well, tomorrow it'll be 100.2. And after that, it'll be 101.3. And then the next day it'll be 99.6. Who knows? When they make up their mind about something, let me know. All right. Again, all of these things can be any causes of a fever, right? Literally anything can cause a fever. Okay. Hopefully they don't have lupus as a child. All right. That would be no fun. All right. And then, right, there are times where you go to grandma's house and grandma's got the heat cranked at 78 degrees, and you're there at Christmas time wearing your Christmas sweater and your pants, and the sweat is pouring off of your face. And you're like, I'm gonna go outside for like 10 minutes and just sit in the snow and cool off, and I'll be back. Right. So again, the environmental temperature, right, can also cause a fever. Right. So just be careful. Rectal temperatures are the best. We don't have anything that you can stick in a child's rectum for a temperature on the ambulance. All right, we have the nice little skin thermal ones that are from China. They're about $5 each. The instructions are in Chinese. There's no comes up on Celsius, and like you have to do the math yourself. I have not had one that's read higher than 96.9 on anybody I've taken a temperature on. Like I can feel your your forehead and it like hurts me to hold my skin there. It's that hot, and I'll run this thing across it and it goes 96.9 or whatever the Celsius derivative of that is. But when I do the math, it comes up to like 96 something. And I'm like, oh, right. So I don't use the ones we have. We don't have very good ones. I wish we would go back to the kind of the ones they have in the doctor's office. We put the little plastic sleeve under your tongue, right? But they won't do that for us either. Okay. And the arm is also pretty good for a core temp. But like anytime you have a hyper or hypothermic type event, like the rectal is your best core body temperature. All right. So for children, they will always get a rectal. But you just do the best you can. All right. And then basically everything's still the same. All right. Fontanelles could be bulging. Okay, because of swelling. So just again, watch those. Febrile seizures. We've talked about these a whole bunch. All right, usually only between 6 months and 6 years. Okay, is where they're febrile after that. They're usually a diagnosed condition. Okay. It's usually just a fever. All right, there's no type of bacterial infection or anything involved with it. Usually the kid has a fever, has a seizure, will happen the first day the fever shows up. All right, it's generally what we would call a grand mal seizure. All right, they usually come right back out of it. Okay, little to no postictal time. All right, and it could be a sign of something else, or it could just be they got too hot. All right, so again, we're gonna try to cool them down. All right, ice packs on the chest and the armpits. I really wouldn't do it on the forehead just because you might cool them down too quick. All right, and then take them to the hospital. And these are ones, Joe, I would not leave home. I said, these are ones I would not leave home. I would strongly caution the parents to either like get in the car and I will follow you to make sure you take them there, or let me take them and you come with me. But yes, there's not many things I absolutely take to the hospital, but there's a couple. All right, drowning or near drowning, right? So it's basically a hypoxic event, right? Secondary to hypothermia, or the hypothermia becomes secondary to the hypoxic event. All right, and then jumping, all right, where they say no diving, but we all know as kids we still run off the end of the dock and jump in, and sometimes it's like this, you know, depending on the tide, it could be 1 foot, it could be 4 feet, right? So be careful, find out what happened. I would say check the water depth, especially if they jumped. Like if they jumped in the water, I don't know what happened. All right, we'll see. How deep is the water, right? Is there a possibility they cracked their head on it? Right? Not saying jump in the water, but if you can see the sand or the rocks like through the water where they jumped, it's probably a good indication. Okay. So again, if it's a near choking or a near drowning, right? Coughing, choking, possibly an obstruction. Did they swallow anything while they were in there? Did they aspirate? Seizing, unresponsiveness. Are they pulseless? Right? Did they swallow a whole bunch of water? Is there abdominal distension? How long were they down there? All right, all the common signs of drowning is the same. And then same way, right? Manage the airway, suction if necessary, call ALS, give them oxygen, CPR if we need to, right? Especially cervical collar if we think they hit their head, right? It's all the same. Nothing changes. It's all the same. Okay, pediatric trauma is the #1 death of children. Okay. Again, Mark told us all about, you know, the growth plates and how things are changing, which causes things to break in a little bit different ways. All right, so femur fractures are kind of rare, right? You won't see them because they should be sitting in the back, right? Nothing should actually impact into their legs or cause that force to break the femurs. The older children with their legs up or laying on the back seat or doing whatever they're doing, you might see some different injuries. All right, but kids that are still in car seats are usually pretty good. You might possibly have a little mark in the sternum where the harness collects, but that's about it. All right, so again, you're just going to have to do that quick physical assessment, right? Find out where the injuries are. Okay, because the padding is different, the bones are different, and the different stages of development will show you different injuries. Okay. Again, because the head is larger, all right, and the neck is not as strong, all right, we worry about whiplash in children. Okay, so be careful for head and neck injuries. All right, always I always use collars in traumatic instances just in case. Like I said, I told you my lady who fell in drunk and fractured C1 and C2, and she kind of made me have a rule: everyone gets a collar, so whether they need it or not. So vehicle collisions, again, we're not going to get crazy into it because you guys don't do that much, but head, spine, abdomen, pelvis, or legs are the highest areas. All right, so that basically leaves like the chest and the arms as like not so bad areas. And then sporting events. All right, every sporting event usually has an EMS standby attached to it. Nowadays, especially football. I don't know if baseball does, but football, soccer. What else? Huh? The track? I don't know. I've never been to a track one. I know I've done football. I've done soccer here. I've done horse trials, both kids and like kids horse riding events, equestrian events, and the actual ones in Millbrook, like the Olympic horse trials. What is the Duchess Day School? Just started every one of their sporting events. They started having EMS out there for all of their sporting anything, baseball. But that's the first time I've ever done baseball standbys. Mostly contact sports. Right? Again, head and neck injuries, concussions. All right. A lot of times they're asking us about concussion protocols. Like we don't have any concussion protocols. Like we don't do any type of orthopedic sport injury concussion protocols. All right. I leave that on the team. I leave that on what their protocol is for if a suspected concussion. All right. If you suspect one, the kid should come out of the game, right? They should go get evaluated. Whether the parents want to take them or you want to take them, again, that's up to the parents. Okay. But they should fall into the same concussion protocols as like our professional athletes at this point. So I already told you why we're worried about the head, right? The head's a lot larger, it's softer. Okay. They may have unnoticed brain injuries. Okay. Depending especially on how old they are and how developed they are, you may think it's just normal, but there's actually something going on, some kind of swelling or bleed. All right. So the head and face bleed a lot. It's all kind of superficial. Unless it's actually coming from like inside, but if it's just a laceration of the face, right? It's highly vascular, but it's usually will stop pretty easily. Okay. Nausea and vomiting in suspected head traumas are your go-to signs. All right. And then especially in the face of a trauma. Okay. So immobilization, we have the boards. It's mostly how you're gonna do kids is the board splints, usually the smallest one you can find. Again, if you can keep them in their car seat, right? We talked about the car seats. All right, I talked to a couple other CICs. Apparently the New York Department of Transportation says do not use car seats. However, there are no like alternative options for like physically restraining infants in ambulances. So we always take the car seat as long as it's not deformed, right? I will show you the one PD seat harness thing that we have, but it's not, I don't trust them very well. Like I like the car seats. You can put the seat belts through those car seats the same way you would in a car, and you can get that thing pretty well strapped to your stretcher. And if I don't know, anyone has a spare car seat and wants to bring it in, I'll bring a stretcher and I'll show you how to cinch them down if you want me to. All right, do you still have one or no? Huh? Okay, I don't know how old your kids were, but I think she just had a son, like she's told me, so I wasn't sure how old her child was.
I have a car seat.
I'll see, there you go. I would have thought your kid was younger, but that's just me assuming things. So if someone has a car seat and would like to bring one in, I don't care who it is at this point. I will gladly show you how to strap it down to a stretcher during lab. Whatever lab day we decide is pediatric day. I will let somebody know, or I'll send out an email. Okay. Again,
Okay.
be careful where the padding is. All right. We don't really pad the same spots in adults. All right. We got to pad under the shoulders, under the torso. Okay. Because their bodies lay a little bit differently than ours. All right. Chest injuries are all blunt trauma. Usually, hopefully, they didn't get stabbed by something. Okay. But we're not going to say it can't be penetrating. Again, look for flail chests is the most common. All right, especially if they're not buckled in properly. Okay. Again, there could be, again, as same in adults, right? There doesn't necessarily have to be an outward presentation to have an inward chest injury. Okay, so again, most of these things we all manage the same way. All right. Again, we've talked about compensation. Okay, so we talked about shock. All right, we talked about hypothermia. All right, so this is the shock diagram that is in your textbook. All right, and basically what they're saying is that more than 25% blood volume loss in a child will give you where a shock will start, right? So somewhere little around 75%. All right, however, adults require 30 to 40% blood loss, so they can lose a little bit more blood before they get to shock. All right, but they will also show it better, right? Because we talked about it. So they're pretty much the exact same, right? Shock is the same, tachycardia, poor cap refill is hypotension, right? And mental status changes. It's just the amount of blood, and that's simply because adults have more blood than children, right? So the ratio is probably still the same when you do the volume to ratio, but just remember they compensate better. Burns, right? We talked about the rule of nines. Okay, so just remember that one. All right, there's more surface area on a child. Okay, so they're going to react more adversely to a burn than an adult will. All right, and again, be careful of shock, right? So we all know about the burns, how children get burned. All right, they're curious, they grab things happen. All right, most of it is accidental, hopefully. Okay, so again, as with adults, infection is the one thing we're worried about, right? Because now we have open pathways into the body, right? The skin is no longer protecting everything, right? So we decided on dry dressings, right, for burns. Dry dressings. It wasn't moist sterile dressings anymore. They were dry sterile dressings. Okay, so dry sterile dressings, make sure it's wrapped. Okay, depending how much burn there is, probably call for ALS for pain management. All right, we can definitely give out some pain meds to some kids for burns. Okay, right, because we're mandated reporters, worry about child abuse, how, why, what's the situation, right? The hospital's probably going to report something. So that's up to you whether you want to make that report for yourself or not. I always make sure there's a very high index of suspicion before I start reporting things. Okay, again, it's all the same. Hypothermia, shock, right? Blanket, oxygen, O2. Right. It's all kind of coming down to the end. I wish we could all do this in one like lump sum. Spend like 2 days on like just everything. I didn't have to repeat myself a million times. Okay. Arms and legs, we talked about this, right? The bones are still growing. So depending where it breaks, especially if it's one of those growth plates, all right, there are weak spots, and any type of fracture in a child we call green sticks. Definitely know that word. You'll see that one again. Okay, they like to ask about green stick fractures. They also like to ask about spiral fractures in kids. Again, we splint them. All right, if you can get ALS to give them some pain management, that's great. If not, take them in. So pain management, we do what's called the Wong-Baker face scale. All right, you're looking for basically the grimace level. All right. I should put a picture of that in here. So in adults, we always say, can you rate your pain from 1 to 10? Right? The worst pain you've ever had in your life, blah, 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 blah. And everyone's joke is they always say what? Huh? A 10? Or
100.
or an 11? I always get 11. Oh, it's like an 11. Like, yeah, all right, cool guy. All right, so this. All right, so why did that not move over to you guys? How about now? Their faces up there now? No. Everybody at home has faces, right?
We have faces.
Okay. But people here do not have faces. Why? Oh, I know why. All right. You still have faces or did it go away?
They're gone.
They're gone. Of course they
Yeah.
are. That's all right. We can fix that. All right. Everybody got faces now. All right. So this is basically your Wong-Baker face scales, right? So you look at the patient, you look at the kid, and whatever their face looks like is how we determine the level of pain that they're in. You can ask them, all right, or you can palpate the area and try to see what reaction you get out of them, and then determine where you want to call it based on these faces. All right, but this is how we do. If it's an older adult, like a teenager, you can ask them 1 to 10 and possibly get an answer. But again, no one will fault you for using the faces. Definite, like under 12, I would definitely just use the faces to be on the safe side with. All right. So that's that. That's simple. Any questions on the faces? Slideshow from current. That is still the faces. How about now? Everyone got the slides back?
Yeah.
Okay. Where are we at? We are. All right, we're gonna get through this. We'll take our break on abuse, and then we'll do abuse and SIDS when we get back. Yeah, we did all that. We did shock already, right? This is why you need a producer. Bones, burns, burns, burns. Rat burns. No, we're just gonna start in shock again. Like 3 times I've tried to get it to move over. Talking about burns, 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 burns. Pain management. All right. I guess we're taking 5 minutes. Take 5-10 minutes. I'm gonna get this set up for geriatrics to go next. There were there, there were no inspectors, no state employees. I'm sure nobody had the proper certifications to even be working there. This client probably thought she was running an underground slave labor shop out of the garage. All right, so since we're mandated reporters, we should probably sit and talk about what actual child abuse and neglect is, okay, for a little bit. So the actual definition is any improper or excessive action that injures or otherwise harms a child, which can include physical abuse, sexual abuse, neglect, and or emotional abuse. Okay. So to be a reporter, we don't have to be able to prove any of it. Okay. We just have to be able to suspect it. All right. Again, that you don't have to prove it. Like you can see signs and symptoms that can be completely benign, and you may suspect because you're seeing size up in your assessment and you're going to make a judgment about the living situation. Okay. And all right. And then you will either decide to call that phone number or not call that phone number. All right. Once you put in a report, the state will send someone over to investigate the report, usually within the same day. What's the matter, Joe? Everyone's taking it already, so that's going to take it. Look at it and don't touch. Okay. Okay. She did or we did? Okay. Right. So look, don't touch. Right, but yet you're going to collect the evidence in the. No, because you're going to, that's why that goes into a paper bag when you're done, or that you leave it there, because they can collect the evidence off of the pad. But you don't want the blood to wash the evidence away onto the stretcher where they can't get it. So like you still put your sheets, like you give them everything. Anything that has blood on it, you give it to them. The look, don't touch one. Basically, if they're hemorrhaging and they say I put a tampon up there, you kind of have to make sure that it's still not bleeding. Like you can bleed through a tampon. Right. So yeah, so you're going to look and then you're going to intervene if necessary. I mean, if it says look, don't touch and it's stopped, then. But you would definitely look. Sexual assault, you're not going to clean. You're going to try to, you still have to stop the bleeding. You can't just let them bleed. Right. But you're just going to put a pad there and you're going to leave it there so that it collects everything in case there is evidence there. Right. Or you can give them the pad to have them put the pad there. Right. You still have to stop the bleeding. You can't just let them bleed. So. Were they both sexual assaults, or I'll look them up? What'd you say? She misfired a tampon? Okay. All right. We'll take a look. I'll take a look on the next break and we'll see where that one's at. No, did we pause? Or is this just dead? Oh, that's working again. All right. Okay. So signs and symptoms, right? Again, I preluded to this. Okay. You're going to walk in and you're going to find a situation, maybe a socioeconomic situation, where you're immediately going to draw some sort of conclusion. All right. Bias, whatever. All right. And you may think that the patient's being abused when they're actually not. Okay. So again, you know, do they have the basic comforts? Do they have like heat? Do they have food? Do they have running water? Right. I went to one house to pick up a kid and the whole middle of the living room floor was literally rotted away. You could like see the ground underneath because they didn't have a basement. They had a little sub basement. All right. Apparently that's considered livable conditions because I made a call and that kid is still there and that hole is still in the floor. All right. They had a fireplace going and they had all that other stuff and it was warm. I was like, but you know, that is I mean, I know the kid knows it's there, but it's a fall hazard. It's a risk. Apparently that wasn't enough. Right. But again, so like, you don't know what you're going to walk into. All right. So be careful, be objective. All right. So is the injury typical for the child? All right. Are there hand marks? Are there hand prints? Right. Are there cigarette burns? Okay. You know, were they being disciplined and maybe the parent got a little too aggressive with discipline? All right. Again, that's not really our decision, but you know, did it happen once? Doesn't happen all the time. Okay. Is the MOI or the NOI consistent with the injury? All right. Is the caregiver like actually concerned for the kid, or are they standoffish, aggressive, don't want you to touch them, don't want you to be there, like I didn't call you, yada yada yada, all that good stuff, right? So is there alcohol and drugs? Okay. Are there different levels of healing like within the wounds that are noticed on the child? Right? Are there older bruises, newer bruises? Okay. Did they say it happened at 8 o'clock in the morning and they called you at 6 o'clock at night? Right. So is the child afraid of the parent or the caregiver? Do they not want to be anywhere in the room with them? Do they immediately come running to you and like let them pick you up and stuff as a perfect complete stranger? All right. So we talked about the different healings. Okay. Talked about the bruises, right? Are there multiple types of injuries? Okay. Are there any type of burns? All right. I don't know. Somewhere along the line, I heard that, grandma used to discipline by running your hands under scalding hot water. All right. Well, that's causing burns. All right. Or your feet. Like they used to tap the bottom of your feet or pin the bottom of your feet or, whatever. People were sick. Okay. So it may happen. All right. It may be completely inconsequential, right? Mom might have started the bath, walked away for 2 minutes, the phone rang, kid might have got in, she might not have had time to adjust the temperature, right? And they may have a scalding bath line on them. Okay, but was it intentional or was it accidental, right? Again, that's all stuff that we have to figure out. Okay, what's the level of consciousness? Is it normal? Is there a reason it's lesser than what it should be? All right. Are they clean and are they being fed? Right, basic needs need to be met. Okay, and is there any sexual assault type injuries? All right. I'm not going to look at every child's rectum and vagina to see if they've been assaulted. That is not what I'm telling you to do. All right. Only if for whatever reason you have a feeling, right, that is something that needs to happen. Okay. Or if you have a woman partner and it is a young female child, right? Like say, go outside, right? Ask them, hey, do you have the same vibe I'm getting? Like, do you want to do a full assessment of the child? All right. And then try to I wouldn't say put the child in a private room because then the parents can be like, what are you doing? But I would definitely have the cops there, right? These are situations the cops are always there. Have the cops there with you, tell them what you're thinking and ask them if, that they agree with it. All right. As long as you have a bunch of people on board, right? Protect yourself from that liability. Okay. So again, we talked about, right? What does the home look like? Clean, dirty, warm, cold, food, right? Again, we'll go back to my giant hole in the middle. It wasn't the cleanest place, right? It was cold in there. Like they were trying to heat it, but it was cold. And I mean, there was stuff mounded over the stove. Like it hadn't looked like it had been used in a couple whiles. Not gonna say years, but in a while, right? So that's why I called, because it didn't really look healthy. All right, but apparently the state said they were doing the best they can, which is fine by me. If they are doing the best they can, that's the best they can do. It's a shame, but so the mnemonic child abuse, right? Are the injuries consistent? Is there a history? Okay. Are the parents being inappropriate? Were they supervised? Did they call right away? What's the affect of the child? Right? Bruises, unusual injury patterns. Is anything suspicious? And what does that environment look like? Right? So I don't know if you'll see that one again. That's sort of a newer one. I haven't seen that one in a while, or I just seen that one in the last year or two. Okay, so look at the bruises. Okay, are they pink and red? They're brand new, right? Are they blue, brown, yellow, purple? Okay, are they starting to fade? Are they fresh? Where are they? Are they on the back? Are they on the butt? Are they on the face? Are they on the arm? Right? They get grab them by the wrist and like yank on them. Okay, what did they do? Or what happened? All right, burns. Again, people are sick, right? So any burns to the genital areas are probably intentionally inflicted by someone else. Okay. Again, glove-shaped burns, like if it's a hand burn or something, that's also done by someone else. All right. And again, if you see little round cigarette scab burns, right, that's obviously hopefully not inflicted by the child themselves. Okay. So just watch out. The upper arm or the femur, right, your humerus or your femur are fractured. That's usually from being either yanked, pulled, hit, beat, something like that. Okay. Bumbles bounce. All right. So when they hit the floor, they usually don't break anything. All right. So anytime there's Any type of long femur fracture bone in children, right? Be suspicious. Okay. Shaken baby syndrome. I think we talked about it a little bit. All right. But mostly it's intracerebral hemorrhaging, right? From being shaken. Okay. You may have an actual, they can injure the spine, cervical spine at the same time, right? May have a internal decapitation partial that you don't even know about. All right. Usually unconscious. And usually no one knows why. They're just there. All right. And then overall neglect. Okay. And this is, like I said, basic life necessities: water, clothing, shelter, hygiene, comfort, safety. Okay. It's a sad part of our job, but it is a part of it. You have to be aware of it. Okay. They may be withdrawn, fearful. They may be aggressive and angry. If they don't want to talk about things, like, no, I'm okay, I'm good, or like they're just very off-putting, not very concerned, or every time you ask them a question, they look to the parent first before giving you an answer, right? To kind of see like what type of response they're allowed to give, maybe. All right, which is a good reason why we interview them alone, right, with police and the parents not in the room, right? The door shut, let the police talk to them outside somewhere. Okay. If the kid is accident prone, right? I mean, some of us, maybe we are a little clumsy and we were accident prone, but like they're accident prone, right? Be aware. Mom tells you one story, dad tells you another. Okay. Or if mom is also afraid, right? You ask mom a question, she kind of looks like, how am I supposed to answer this? Or she wants to say something. What is the oh, see, I'm horrible, I forget this one. What is the, anybody know the universal sign for abuse? It's mostly for females, right? Isn't there like a hand sign?
Yeah,
Yeah.
I think so.
The thumb in
I
and
think
the
it's like
over,
closing a fist or something like that.
right? So like if you see like mom do that, or yeah, something, all right, just be aware. Okay. And it doesn't always have to be mom or dad. Could be the nanny, right? How many nanny cam footages have you seen? Like people get the little teddy bears with the cameras in it to catch their nannies doing, and they see them abusing the children, right? You see that on the news every once in a while. So could be anyone. All right. Like I said, all healthcare workers in New York, most states are all reported mandators, especially with minors, the elderly. When we get into geriatrics, we'll talk about, we're not mandated. Okay. But if you still think that they can't take care of themselves, we have the ability to report. They take a little bit longer. The state's not really concerned about old people too much. They kind of, you make the report within the week, they'll get out there and check on them. All right. Kids, usually within a couple hours. All right. And then again, no one can tell you whether or not you report or not. All right. That's entirely up to you. Okay. No one can tell you not to. All right. And then the police on scene will start their own investigation. Then CPS gets involved and you may have to testify. Your phone interview might be enough. All right. So sexual abuse, right? We talked about a little bit. Okay. Any age, any gender, doesn't matter. Most often by someone they trust. Okay. Again, do the best you can based on how they're dressed. Like I said, I'm not really going to make a child take all of their clothes off so I can see. All right. But you do what you feel is comfortable with. All right. Bruising and fracturing, right? Obviously that's what they're there for. Okay. And then again, unless there's evidence of bleeding, like in an adult or any type of severe injury where you think you might have to do something. Okay. Same thing, right? Don't let the child wash bathroom, okay, until they do their exams. Again, same sex is usually what's the word I'm looking for? Not required, but what's the word I'm looking for? Recommended. Yes, thank you. Right. Same sex is usually recommended. Again, this one is going to be your hardest part, right? Because you're going to have your own feelings about it. It's almost impossible dealing with children to make that separation. Okay. So try to maintain your professionalism the best you can. All right. Focus on the child, and this should be easy, right? The caring and concerning part. All right. If you start focusing on what's going on around you, you're going to lose sight of this, and you may get involved into the shenanigans of everything else going on, and that you don't want to have to deal with any of that. Right. And then be as discreet as possible. Okay. I had one. So my second patient this morning, apparently I've never heard this one before. This is a brand new one in 10 years. He's on blood thinners. He's on Xarelto. And apparently last night he brushed his teeth a little too vigorously and started bleeding from the mouth. I'm like, okay, I've never been that aggressive with my teeth brushing before, but he even said, he was like, yeah, he's like, I just got a little out of hand with it. And I'm like, the hell do you mean you got out of hand? Well, like, what the hell were you trying to do? You have no teeth. Like, all of these were missing. The whole front, like 8 teeth were gone. I'm like, how vigorous could you have gotten? Like, there's nothing there to brush. But walked in, right on the kitchen counter, there's a 32-ounce McDonald's cup full of like dried blood and mucus that he had spit up, like that he'd been bleeding out. And there was a bunch of rags on the floor, and he was sitting half naked on the living room floor. Like, he's like, I got tired. He's like, I couldn't walk around anymore. He's like, this is where I sat. He's like, and I forgot to grab the phone. So apparently he eventually got to the phone, called his son called us. But this guy, right, he asked me, he goes, oh, so you took that woman this morning? And I was like, what woman? He goes, and he used her name. He's like, the woman from the specific address in Dover. And I was like, I can't tell you that. He's like, what do you mean? I was like, I know you have a scanner, and you know that I cannot tell you who we took, but you know who I took this morning because you're asked, you know the address and you know her name. I was like, so, right, like, but I mean, again, as part of discretion, right, he was monitoring the radio, and he was more worried about asking me questions about the lady that got transported this morning before him about like his own self, right? So just be discreet, right? You can't give out that type of information. Okay. I felt that was a little weird. He's like asking me about her, and I'm like, worry about yourself, sir. You bled out overnight, and like you're sitting here on the floor, hypothermic and cold, like naked. I had to get you dressed before I could get you in the ambulance. Like, he's worried about other people. And that's just how some people are, but so we try to be as discreet as possible. Okay. Back to this. Yes. I mean, my gums will bleed, not my actual teeth. Like, if you get a little aggressive, like I have the Oral-B spinning circular one that does it for you. It's like if I hold down too hard or something and it starts vibrating, like my gums will bleed, but not enough where I could fill up a 32-ounce McDonald's. And even on Xarelto, like a small gum bleeding should not produce 32 ounces of blood. Yeah, no, I mean, like he was doing something else happened. That's not like you lacerated the inside of your mouth or something. Like I don't know what you were doing. Okay, but like that's not, the story does not match with what I found on the scene. Like, you don't bleed that much from brushing your teeth. No. And he had like all dried blood on his face, on his shirt, like where he was just like drooling blood all night long while he was sleeping against the wall. Like, he was in rough shape, but I don't think it was. You have a teeth fragment in there? I mean, there were random sporadic teeth in there. Like, it looked like, your old man with the one tooth here and the one tooth over here, and just pull them all out and get dentures. Right. But I don't know. So yeah, he was a little his story didn't I would have thought he would have got assaulted, except there was no bruising on his face. Like all of his teeth were missing, he was bleeding, and there was way more blood than a toothbrush should cause. But whatever, it is what it is, right? Transport everybody. Okay. Recording music. All right, so again, it is a crime scene. Basically, you know, same as if any other crime scene we operate on, right? Just cooperate with police, do what they ask you to do. All right. If they may want you to give a statement, give statements. Usually, most times with these, you will do your transport, and then they'll either say, when you're done, can you stop by the nearest substation, and we'll get your statements then. So you'll go out of service. You'll go down to usually it's the nearest state trooper barracks. All right, and they'll have you fill out a statement and sign stuff. All right, so just whatever they ask you to do, just remember, right? That's what we're there for. No, we're gonna do this again. Okay, so we have two now. It used to be just SIDS, sudden infant death syndrome. Now there's sudden unexpected infant death. Okay, so again, it is more, I guess, a general umbrella term than SIDS. Okay, SIDS was apparently not the answer for all generic sudden infant death. So until autopsies and investigations were done and they found the actual root causes, okay, they came up with SUIDs, right? Because let's just make things harder on ourselves. All right, again, they're almost the exact same thing. However, SUID is an unexpected death where the cause is not known until the investigation is conducted. All right, so the autopsy, whatever, okay, maybe it was genital heart defect, maybe it was choking, maybe they were something ruptured, right, whatever. Okay, one of the causes of a SUID is SIDS, all right, which has no explanation. You can do all the investigation you want and they have, it's like, no idea. It just happened. Okay, there's literally no medical explanation. Okay, so 3,500 infants die of SIDS annually. My first cousin at about 6 months died from SIDS. All right, sent my uncle on a bender I don't even know if he's back from yet, even though he's got a 24-year-old daughter. Pretty sure he's still out there. All right, so it messes people up. Okay. Again, they're just saying when you put your baby to sleep, all right, because usually it's found while they're sleeping. All right, usually you wake up the next morning, they're usually passed away in the crib unknown, don't know why. All right, and it's not from suffocation or anything, but again, on their back, mattress firm, no blankets, no toys, right? Nothing they can wrap themselves in, suffocate themselves in if you want to swaddle them before you put them in there. Okay. They're recommending that you do same sleeping, but not co-sleeping. Okay. Again, for the same reason, co-sleeping, you can roll over and suffocate them. All right, which was the most probable cause of the SIDS that I did about a year ago in Germantown. All right, was they were co-sleeping, and when she woke up, the baby was limp and blue. All right, so and for whatever reason, through the Infinite Medical Research Wisdom Knowledge Handbook, breastfeeding a pacifier lowers the risk. Okay, I don't know why, but if you plan on having children, just keep it in mind. Okay, so risk factors, again, through all the research they've done, teenage mothers, any type of malignancy during the pregnancy, so smoking, alcohol, illicit drugs, premature, low birth weight, okay, any of those predetermining factors that we talked about in the last chapter, right? And again, and it couldn't occur whenever. It doesn't necessarily have to be while they're sleeping at night. It can be any time of the day for any unknown reason. All right, this is what we do. We assess the scene to make sure that it was SIDS and not some sort of abuse. Okay. We assess and manage the patient, make sure that they are, not recoverable at that point, or that CPR is not going to work. Okay. And then this next part, actually, after we do the assessment part, the communication of how to tell someone their child is dead. All right. And all I'm going to say is good luck, because I've been doing it for a long time and there's still no good way to tell someone, even, an adult has passed away, let alone telling someone that their child is now gone. So there are strategies for it. However, you do the best you can in that situation. Hopefully you've called ALS and there's someone else there who takes that responsibility from you. Yeah, put that on our shoulders. Let us handle that. Okay. So they'll be pale blue, cyanotic, not breathing, unresponsive. Again, it's usually been a while. Okay. The obvious ones. All right. You can have a victim of SIDS and we can go and do CPR and it may or may not work. Usually it won't. All right. But there could have been some sort of infection, child abuse, airway obstructions. All right. Meningitis is a cause. Okay. Accidental or intentional poisoning. Low blood sugar, which is why we always do a sugar during cardiac arrest, right? Or just they succumb to their congenital defects. All right. Not all children are born perfectly healthy. It is it's an unfortunate thing, but okay. Sure. I mean, well, so this is the thing, like, yep. 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 And then, right, do you have the balls to sit there and look mom in the face as she's sobbing and swinging and crying was, why are you not doing anything for my child? Or do you just take the baby out in the ambulance, pretending to do CPR on the way, and then drive to the hospital and let them know that you're incoming and this was the situation and why? And that's entirely, yeah, up to you guys. Those are personal decisions. All right. We transported the one obvious SIDS one, like I said, in Germantown. It was painfully obvious and we did it anyway. And we did it mostly for the brand new EMT that was working that morning, because you could see that they were not handling the situation very well, about everyone just kind of standing around not doing anything. Like, and she's a mother and she really wanted to get involved. So we got involved and that made her feel better, right? She was able to go about her day knowing that she did something, even if there was like, I mean, and we had to have that conversation with her on the way back because it was me and another paramedic and we were like, there was literally nothing we could have done. And like, we did it so that you felt okay. And that we literally told her, like, we did this so that you felt okay about what happened. I was like, but there was nothing. That child had been gone for a long time before we got there. No, because you say the same thing. You bring it in. Well, why'd you bring it in? Well, because mom and dad were flipping out on scene. The cops said, no, get out of here. It seemed like it was a good idea just to bring in. It is a kid, right? So we gave it a shot, and the hospital's not going to fault you, right? Most of the nurses are parents. The doctors are parents. Like, everyone understands it's a kid. Okay. I try to, I tell you to do your best to separate yourself. All right. But you put in certain situations, certain instincts take over others. All right. And you just are going to, even though it's an exercise in futility, you're going to do it to make yourself feel better so that you can say, I tried and I didn't just let this kid go, like, for no reason. Right. Sometimes that's what it takes for you to be comfortable with your own decisions, right? You have to be comfortable with the decisions you make. Right. Otherwise, we go back to chapter, whatever it was, with, EMT suicide and stress and PTSD. And right. There's decisions we have to make out there and you got to be able to live with it. So if you need to transport a SIDS baby while doing CPR in order to make, to get yourself through that call, then that's exactly what you do. No one's going to say a word about it. Okay. And if you have ice in your veins, then you can sit there and look at that baby and be like, I'm not going anywhere. No one's going to think of you any less. Okay. Because you're not doing anything medically wrong, right? You're making a clear medical decision that the doctor has to make on a daily basis. You're doing the same thing, right? It's just, you have to make that decision as a provider as to how comfortable you are. But yeah, I mean, if they're obvious signs, right? There's no matter what we do, it's not gonna change anything. So, all right. So again, if you can provide interventions if necessary. Okay, hopefully, again, because they're not always that far gone. All right, they may walk in, it may still be within the first couple minutes of the event happening. No one knows. All right, so you're going to try. If they're still pink and warm, we're still going to try, right? But if they're pale, cold, stiff, mottled, eyes are glazed over, people are dilated, like outside, like they have no iris, it's all just black pupil, right? Again, you can try, but your chances are slim to none. Okay. Again, like he was talking about, depending on the time, okay, there could be post-mortem changes, right? If you see them, call med control, tell them, let that doctor make that decision. Then you can explain to the parents that, the doctor doesn't want to see the baby. Like he said, there's no reason to bring it. All right, maybe you can pass that onus off to the doctor. So, but again, if there's no signs, right, start CPR. Okay, so again, do your quick assessment, right? Try to rule out abuse prior. Okay, and then if anybody on scene did anything before you got there, right, we want to make notes and documentation of that as well. Okay, so inspect your environment, obviously. Okay, noting how it looks, where they are, what's going on, how, right, what's the condition of the house, what's the family interaction. Okay, was there any family interaction? Do they even care? All right, are they in complete dumbfounded shock and they just, like, they do care, but they don't know how to process what's going on right now, right? Because now, again, you have two patients, you have the child, and now you have the mother or father, both are right, who are going to run their gambit of emotions in about 10 minutes flat. Okay, so again, you're there for them now, right? If you stay there, if you don't transport the baby, if you've decided that it is obvious and that it is pointless, okay, you can try to deal with that very strong emotional response of why you did nothing. And I would suggest not staying there much longer. Okay, because you literally just stood around and did nothing for a child while their parents were there watching. And again, you'll find out that that's not the best. People get very protective of their kids, right? So we do what we have to do. All right, and then try to help them through the stages of grief if you can, right? Being as professional as you can with the notification. They more than likely already know. Like I said, most oftentimes they're obvious. Okay, so it isn't. Police will usually respond in any way. Okay, they will. They get dispatched medical advisements for every call that goes out, and then they decide whether it's something they feel like sounds suspicious or they want to stop by. Any type of, so that would be an echo level call. Yeah, that's an echo level call for cardiac arrest, and the cops are going to be there probably doing CPR before you, unless they look at, if the cops take one look and they're not doing anything, that should be your first clue. All right, if the cops are like, yeah, no, we're good. All right, that should be your first clue. Okay, that the non-medical medical professional says that it's been better. Right. Ooh. Good times. All right. So again, the family is definitely going to want you to do something. All right. It may or may not go against protocol. Like I said, we had the conversation, right? The hospital's not going to fault you for it. All right. Try to find someone. Hopefully the officers are usually really good about being able to get demographics for you while you're working. Okay. Or once they've already been asked those questions, like again, going through their stages of grief, I don't really ask them again. I'll just be like, hey, can I get a copy of whatever you wrote down for my chart? And the cops are like, yeah, sure, cool. So obviously don't tell them why you think their child died. All right, that's not helping anybody. And we're not experts. We have no idea. Okay. Again, we don't take the body away. So if you want to let them hold them, do everything until the coroner gets there. If the police are okay with it, if it's not like a crime scene, right? Do everything within, make sure everyone on scene is okay. All right. And then if you have the name, right, use the name. Okay. Eye contact. And then, you know, people don't like passed away or gone, right? Just, I'm sorry for the death, right? Or I'm sorry, Brian is dead. Okay. You just kind of got to be as not unsympathetic, right? You don't want to come across like cold and like not caring, but at the same time, you don't want to like play into their emotions. All right. You're trying to help them, not cause more hysterics. Okay. Again, we talked about this, like don't use the words, I know how you feel. Okay. Even if you had SIDS happen to you or in your family, all right, they don't really care at that point. They're not at the point where they're trying to talk about it and like make sense of it yet. All right. See if you can call people for them. All right. Do you want, you know, is there anybody in your phone you want me to call for you? Can I get anything started? Right. Short, simple communications, nothing crazy, nothing extenuous. Obviously wrap the child, swallow it. Don't give them just a cold, naked baby. That's not making it any better and or worse. Well, definitely making it worse. All right. And then everything stays. Okay. Everything stays on scene. Don't take anything away. Coroner usually takes all of it and goes if there was a resuscitation effort. All right. I try to clean it up at least a little bit so that there's not tubes, wires, bags, vials, you know, cords hanging out of their child. All right. Especially if they want to hold them. But depending on how bad it was. Okay. Again, you may end up having 2 or 3 patients. All right. Once you're done dealing with the child, don't just be like, all right, we're good, we're out of here. Like now you're worried about the family. All right. So the family now becomes a psychiatric emergency kind of. All right. And we're there for them. Okay. We don't do home visits. I'm not sure. I only edit it because I don't know where everybody is from and what your protocols are. So there may be follow-up visits, especially for your closure, as well as the family's closure. All right, because it is emotional for you, whether we try to block it out or not. But we don't do that in New York. So, and like we said in the other chapter, right? If you need the day off, take the rest of the day off. Again, no one's going to say a word. All right. If you need to talk with anybody, you guys all have my email, my phone number at any time in the next 20 years of your career or the next 6 months, however long it lasts. All right. If you go out there and you have a double fatal hanging, shooting, suicide, weird thing that happens to you and it's within 2 months and you're like, yeah, no, this is definitely not for me. You can call me in 2 months and we'll talk about it. Right. I don't say no. Okay. Talk anytime you want to talk about anything. All right. Because sometimes you don't want to talk about this, right? You just want to talk and you just need someone to talk to. And if you just want to randomly bullshit about nothing, that's my specialty. Okay. I can randomly bullshit about nothing all day. I don't really have to listen because you're just rambling. You need someone to talk to or talk at. And that is one of my specialties. I'm real good at that. I can do 2 other things while you're talking and I'll pick up the The minorly important things to answer you back. No, I'm just kidding. I will pay attention. If it's serious, I will pay attention. All right. But if you need someone to talk at, I'm good for that too. Okay. Again, be careful for PTSD. All right. And, you know, not just you, but for other people. All right. Don't be afraid to talk to someone else if you think they're having a hard time. All right. We had one of our employees who was having some issues, ended up having an eating disorder, and we got them some help. All right. But just gotta know the signs and pay attention. All right. And then we have these things, our apparent alties or apparent life-threatening events. All right. And these are literally everything that's not SIDS or everything else that almost kills a child. Right. Could be anything, any or anything. All right. So not breathing, cyanotic, unresponsive, and then they start breathing again. Right. That's an altie. It was life-threatening. It is now no longer life-threatening. Okay. There's usually some sort of distinct change in muscle tone, choking or gagging, some sort of unresponsive state. All right. And it usually self-resolves. All right. And again, they need to be taken to the hospital to find out why that happened. Right. That's not a normal thing. All right. So they usually don't have sleep apnea. It's not like an adult who just stops breathing in the middle of the night for 2 seconds or a couple seconds. Right. Airway management, find out their history, their congenital history. Okay. And then obviously there's no way mom or dad are going to let you go without them. And like I said, most times, except for the case of abuse, the hospitals need the parents there anyway for consent. So allow them to come with you. Okay. So like we said, any signs or symptoms, choking, cyanosis, changes in color, altered mental status, any type of irregular breathing, all the way down to no breathing. Okay. However, you do a very thorough assessment and you can't figure out what's wrong, right? Then we just call it an altie, right? When you get to the hospital, you're just like, hey, they had an apparent life-threatening event and it resolved itself, and tag, you're it. Here you go, right? All right. Any questions on pediatrics? Anybody? Everybody good on peds? All right. Take 10 minutes and then we'll do the first a little bit of geriatrics.